Yeah, and what we do for the eye, people want to do the eye test, and it's more of a screening tool for populations, because if you start having this is like, we have a risk continuum, we have a health, a physiological continuum, your biomarkers. But the next phase, as you progress down in the wrong direction, is a pathological continuum, pathology continuum. And the eye is the best place to do that, because you can see vessels, you can see nervous tissue, and you can see formations like amyloids. And amyloids are very prolific in the body when your body's reacting to something particularly infectious. And this isn't me, this is Dr. Tanzi and Moore at Harvard, that showed that most of these unfolded protein responses, like cataract, is actually an antimicrobial peptide. So it's part of the innate immune response. So that's where we're at with that. So, but thanks for the questions and filling the awkward space between 5 minutes of and 5 minutes past when I actually start.
Sorry.
It's good. And there, the doctor's in the house. The doctor's in the house.
Hello. Oh, the other thing about, all these eye diseases, when there's a microvascular decrease, of course, traditional ophthalmologists really don't know anything about how to improve that. So, using things like serrapeptidase, nattokinase, K2, things that help the endothelial dysfunction, such as arginine, citrulline. There's also an amazing nutrient called arterosil that's showing a whole lot of promise in all sorts of vascular disease syndromes. So, and it helps heal the endothelium. So I think that it's going to show a lot of benefits for a whole host of eye diseases when the vessel compromise is one of the key things that's causing the degeneration.
Before we start in, since we're starting on statins, again, a little review, I just want to cover a couple things. But the pictures, and we'll do a lecture on this, but the pictures in your doctor's office of the vessel being plaqued up, I cannot tell you anything other than that it is completely wrong. It's completely wrong. And they show like all this precipitation of junk in the vessel, the cholesterol, okay? But actually, every vascular disease is a disease of the small vessel. And I have a little joke I tell with my participants, not really a joke, but it's sort of a joke. And I say, okay, in your house, what clogs first? A large drain or a small drain? And they all, of course, say a small drain. And my joke part of it is, you now know more than every cardiologist in America and possibly the world, because it's always a disease of the small vessel of the large vessel. Chew on that for a second. But this was proven by a German pathologist by the last name of Koester. If anybody is a little more fluent in German than I am, help me on the pronunciation. But as a pathologist, he was studying diseased vessels. And he showed that really the disease was emanating from the outside into the inside. And I have a whole series of lectures on this, but we'll redo them, make them better, and present them as we go through the year. But it's always the microvasculature. And so what Dr. Carter's talking about is completely right, because you need a roto-rooter, the little vessels where red blood cells go through single file. Okay, and we'll do, maybe in a couple of weeks, we'll talk about red blood cell distribution width again. But anyway, let's get on with it. Oh, the sun is starting to invade here, thankfully, but so my coloration has gone askew. But I want to dive right back into drugs that cause more harm than good. And I think we already talked about this last week, but the statin drugs are insidious because of the gift that keep on giving. You know, my blogs on, Dr. Carter, my blogs on how not to die young. There's 4 hours of video content out there on statins because we show you all the downstream things that this creates. When you lower transport of fats, you lower transport of repair and recovery and anti-inflammatory molecules. And I think those are two things you really want to have working well in your body: repair and recovery and reducing inflammation. And that's exactly what LDL is bringing through your body to keep you healthy. But so I'm not going to go into a big song and dance on the statin drugs. They'll be up on the record, but I have this. So this is what I was talking about. If your LDL is low or lowered artificially, you're deficient in all these different things: vitamin A, D, E, K, triglycerides. They put it twice because it's you can't lose weight well, and it worsens diabetes, fatty acids, critical to eye and brain health, other important fat-soluble nutrients, cholesterol repair and recovery. But what I want to go over right now, which I just added, and I don't want to spend too much time on this, but the difference between absolute and relative statistics, and I'm going to pick it up again at the end of this talk. But the thing is that, you know, I was listening to Thomas Sowell, and if you haven't listened to a Thomas Sowell lecture, Sowell, it has nothing to do with health, but he's just a brilliant guy. I heard him say the other day when I was listening to him, you know, there are lies, damn lies, and there are statistics. So what happens is the drug companies present benefit in relative statistics and harm in absolute statistics. Absolute statistics are the only thing that means anything to you. So for example, if 2 people died in a lightning strike in America last year, and then this year only 1, that's a 50% reduction. But your risk of dying from lightning is 1 over 350 million, or otherwise nil, okay? The same with the benefit that the drug companies are presenting. So here's Zocor, the big study on one of the original statins, okay? And the test was done on high-risk men already diagnosed with severe cardiovascular disease. And just as a preamble, the only reason why they got any benefit is because statins have some minor anti-infective properties, okay? It has nothing to do with the LDL. So it's sort of like pushing the mattress down on one end and it's popping up on the other. It's popping up because LDL is not the right thing to reduce. But they had 4,444 patients divided into 2 groups. So they had, the study was 5.4 years, so 24,000 patient years. Now we're talking about, you know, getting struck by lightning. So they had 182 deaths in the Zocor group, 256 deaths in the placebo group. So what they do is they take 256 deaths minus 128, and they divide it by 256, and they say the benefit is 28%. But that's only 28% if the study was on 256 people. But it wasn't. It was on 24,000 people. Okay? Hopefully that makes sense, and I'll cover it again. So on an absolute stats basis, it was 256 minus 128 divided by, you know, half that number, which is 3%. But that's over 5.4 years, so the absolute risk reduction is less than 1%. But the reported is 28%. Okay, so we're going to go over another case related to eye treatments that show you the absolute increase in mortality. I really can't show you the relative benefit because there isn't any. But
Need to go out?
We'll go over that as well. Okay, so relative measures associations. Blue eyes, more skin cancer. So good. Let's change the pigment in your eye, not the pigment, but the pupil, and we'll change it from blue to brown. Are you going to get less skin cancer? Of course not. That's an association. Well, whereas the absolute measures really are getting down to the true statistics. And I don't think I did a perfect job of explaining that, but there we go. Did we talk about blood pressure medications last week? Because I do 2 different sessions, but
No,
yeah.
no.
And I think we talked about how, we're going to do a separate thing on blood pressure medications.
Mm-hmm.
So my only comment on that is, beside the side effects, this is the story that Dr. Trump used to tell me. He said he had this little old lady that come in with high blood pressure, and she's on her blood pressure pill. And she said, I don't take my blood pressure pill in the daytime because it makes me woozy, but my doctor wants me to take it. But so they just take it at nighttime, right? And you have to get up and go to the bathroom, and then you're woozy and a little confused, and you trip and fall and you break a hip. Most of the blood, the most metabolically active tissue in your body, number 1, the eye, it's always doing work. And number 2, the brain. The brain is 10 times more metabolic than the rest of your body. So when you're artificially lowering your blood pressure, you're in some ways affecting the brain. And guess what? It's the brain that's telling your body to raise that blood pressure. I'm not saying that having elevated blood pressure is not a serious risk, but there's always an underlying cause. So maybe you need to take that blood pressure medication. That's up to your doctor. But ask your doctor, as they say in the ads, why would I have to be on this for life? Can't you find out why and solve that for me? So many cases of oral problems elevate blood pressure. Other inflammation, like Dr. Carter's talking about, cleaning out your vessels with, chelation therapy or some of these other not pharmaceuticals, natural products that'll help pull calcium out. So often there's a calcium disruption, calcium precipitated in your soft tissue that's creating an occlusion in the vessel. And the only way your brain can solve it is increase the pressure to get more blood through that narrowed vessel. So it's these kinds of things that are affected by those blood pressure medications. And once again, we would spend a couple hours on looking at each different medication. So we'll hold off on that. But just be aware that, there's an issue with starving your most metabolically active and important organs, like your brain and your eye. Non-steroidal anti-inflammatories. The main thing we're seeing with these drugs, and I have some interesting case studies. I had a lady with migraines. She was taking 4 medications, including NSAIDs and other drugs, for 23 years. And she was suffering from stage 3 kidney failure. Okay. In your kidneys in each kidney is 1 million little teeny delicate coffee filters called nephrons. And they can be damaged by the aggressive caustic nature of these drugs. Stomach lining, kidneys. So that's why we have kidney failure, things of that nature. And other things that are going on, probably affecting your microbiome, very aggressive things, creating leaky gut syndrome, leading to things not totally digested that now can easily pass through the gut rather than being sent down as a waste. So headache, diarrhea, constipation, affecting the gut, affecting the brain, stomach ulcers, skin rash, autoimmune disease from leaky gut syndrome. All of them titrate back to affecting the gut in some manner or form, which then proliferates. Matter of fact, so many, Dr. Carter states this all the time, 70 to 80% of your immune system is in the gut.
Yeah.
So if you're affecting stomach acid, you're affecting microbiome integrity, breadth and depth, you're irritating or harming the lining so that things are leaking through, or you're damaging organs that are extremely critical. Kidneys, filtering out toxin, liver, your chemical manufacturing plant. all these things have to be optimal in our world of high toxicity, poor food quality. We need all these organs working very, very optimally. So higher risk of heart failure increased by 19%. Ulcers and internal bleeding, cerebral vascular events, renal failure. You know, it's your kidneys that regulate blood pressure anyway. Your heart's just facilitating, but it's really the kidneys. That's why most
Need to go out?
of the
Need to
drugs
go out?
focus
Need to go pee-pee?
on kidneys. No, I already did pee-pee. I'm all set. I don't have to go out. I'm fine for now. Besides, if I'm desperate, I have a cup. Speaking of that, my dogs are in a crate right now because it was rainy. They didn't want to go out. But corticosteroids. Michael, can you talk about corticosteroids and their, you know, I'll put a couple of side effect slides up, but I'm really not fluent on these drugs. You're the hormone expert.
Oh, things what, like prednisone and so forth? Yeah, I mean, they are broad spectrum anti-inflammatory drugs, but, you know, of course, long-term use of those, you know, cause weight gain and just a whole host of side effects. But can it be used as a temporizing measure? Yeah, I mean, when people come in and get a, you know, 5-day prednisone taper for, you know, some mild to moderate hypersensitivity things, but at the end of the day, there are numerous natural supplements that work just as well from an anti-inflammatory standpoint, you know, such as curcumin, and especially in a liposomal form. Because, you know, all curcumin supplements are definitely not created equal. Just so, you know, you go to Costco and you buy curcumin pills and so forth. Highly unlikely that it's going to be very absorbable. If you're doing curcumin pills, you definitely need to have it combined with bioperine, which is a black pepper extract to help increase absorbability. But yeah, the liposomal form, far, far superior. So not a big fan of, you know, steroid creams either. Again, you know, you go to the dermatologist, placed on a steroid cream for eczema or some rash, but it goes back to the gut. You know, your body's telling you something's going on.
Here's a case that Dr. Carter and I worked on a few years ago. The young lady in her mid-30s had polychondritis. And that's a disease where cartilage from here on up would flare up with extreme pain and inflammation once a month. Very interesting. You know, a lot of things are sinusoidal like that. But she had been to multiple dermatologists and even the Cleveland Clinic, and they had no answers for her. And we got to the root of it and started treating her. But the problem is she was on prednisone and Imuran for so long. The prednisone led to this, cataracts. So long-term use. So they're trying to control her monthly flare-ups. Now she is blinded, on disability, cannot drive, can barely watch TV, and cannot get cataract surgery to correct that because her flare-ups are continuing and no eye surgeon will take her on for fear that the flare-up happens during recovery phase and she goes permanently blind. So we treat her gut, we treated her for the usual suspect infections. Oh yeah, and then the Imuran caused a breast lump, so she was having chemo for that, you know, and so just a mess. But we found out that infection was driving a lot of what was going on with her, tied to leaky gut syndrome. And within about 4 months of treatment, we had quelled her inflammation to the point where she could get the cataract surgery, get the replacement lenses, and be able to return to a normal life. And so these are the kinds of things that these drugs can cause when you're on them chronically. And that's really where the issues come up in most of these drugs, is just a chronic susceptibility. You know, they're immune suppressing drugs. So Um,
And it also contributes to diabetes as well with long-term use.
bone fractures, things of that nature.
Yeah. Mm-hmm.
So the anticoagulants, if you go out to Google and type in New York Times old drugs that are at least as good, if not better than new drugs. That's not quite their title, but that's what they meant to write. I had to modify it for them. But the problem with these new anticoagulants is there's no antagonist. So you got to be really careful in life. God forbid you fall down, get into a car crash, something like that. You could bleed out. They don't have a way to stop the anticoagulating factor. So, you know, I've had people that had a little atrial fibrillation, got a cardioversion, reversed it. Now they're on these anticoagulants for life. But they don't have coagulation problems because they're back in sinus rhythm, yet they're still put on this drug. That's not what causes AFib. It's an electrical conductivity issue between the upper and lower chamber. Anticoagulants doing nothing towards that. So many people are put on drugs just as the obligatory thing to write that script and move them on that shouldn't be on these drugs. I've had people on high blood pressure medications that said, I didn't have high blood pressure. But sometimes cholesterol's up, sugar's up, they put you on the trifecta, the statin drug, the blood pressure medication, and the metformin or some other form of glucose lowering pharmaceutical. But they didn't have the issue to start with. So there's no free lunch. That's the thing. It's about that mattress, pushing it under here, it goes up over there. So big problem. So I have let's look at what the blood thinners will do. Once again, you're diluting your blood to some degree, so you're carrying less nutrients. So it's causing hair loss, rashes. So somehow it's affecting the gut again, because these are all autoimmune conditions. In some ways it might be good. It's exposing, like, your gums are bleeding. So, it's showing you that, hey, your gums are bleeding. And now you see it in a big time. But what if you have leaky vessels in your brain? Do you know if your brain is now bleeding? You can see if your gums are bleeding, and you can see a nosebleed. But what about a heart bleed? What about a brain bleed? These are the kinds of things. Dr. Trump, we used to live in Boston, and we were walking on opulent Beacon Hill, by John Kerry's place. And, the cobblestones, all are kind of broken up a little bit, and, grass is growing in between. He says, Dr. Trump would say to me, older people just have more, this is what their cell membranes look like. Everything's a little more leaky as you age. And then you add something that increases the potential for leakage. Not a good thing. Even a little baby aspirin will create more leakage. Not that, I would tell everybody to get off that baby aspirin. You can check with a good functional doctor to find out why you've been put on that and see what your heart risks are by measuring red blood cell distribution, C-reactive protein, homocysteine, repair and recovery things. You may not be on. Run clotting tests, SED rate, and other clotting tests to see where you really are, rather than just getting slapped on the drug in 5 minutes. So anybody who's offended by blatant exploitation of a situation, tune off right now. But here's a simple thing. Arnold Palmer was for a couple of years on Xarelto advertisements. He died on the operating table. Anybody want to know what his cause of death was?
Xarelto.
Xarelto. He bled out. He bled out from the product he was advertising. Couldn't stop the bleeding. The surgery was for something else, whatever the surgery was for. He probably had AFib or something, but the surgery was something very different. And he bled out on the table. So, at least warfarin, nobody likes any drugs, but at least it has an antagonist. If Arnold Palmer was on warfarin, he wouldn't have bled out because they would have given him, you know, vitamin K antagonist before the surgery. Sleep aids. Michael, you want to take that one on?
What? Oh, things like Ambien and so forth.
Yes,
Yeah.
sir.
Definitely another, you know, problematic drug. Because, you know, I used to do a lot with pharmacogenomic testing. And again, all of these, the vast majority of these drugs are metabolized in the liver, you know, and just like everyone is different. You know, you have some people that are fast metabolizers and you have some people that are slow metabolizers. And there was, you know, a significant number of women that they found who were in the slow metabolizing category, and they were on like a standard dose of Ambien. But a number of those women died, strangely enough, just from taking that standard dose. But what they found was those women just accumulated that over time. And that's another thing, you know, problematic with, you know, all these drug categories. Again, everyone has a different way of metabolizing things. So going to a deep dive on that will really, you know, show people where they are. Things like, you know, taking statin drugs. A pharmacogenomics test will actually tell you if you have a high risk of taking a statin drug and it causing what's called rhabdomyolysis, which is breakdown of the muscle, which ultimately, in most instances, results in death. But yeah, getting back to those, you know, sleep aids, it disturbs the normal sleep rhythm. And again, there are a whole host of things that work equally as well, or better rather, you know, things like L-theanine, melatonin, GABA, whole host of things. And again, you know, so if someone just can't turn their mind off, chances are you have high cortisol levels at night, which is keeping you awake and so forth. So, you know, taking supplements like phosphatidylserine will help, you know, reverse that. So, I mean, it's a number of multifactorial things that, of course, that's how we do the deep dive on things to ultimately not just treat the symptom of what's going on. We want to find out why you're having these sleep disturbances.
Right. And, you know, same with the mood drugs. How do they really work?
Right. Nobody knows.
If a doctor is giving you a drug and they can't explain mechanistically how it works, they don't know. I gotta question that.
Absolutely.
Now, what is this? Oh, I'm diving right in. This is something this is the last topic for today, but I'm talking about the, anybody has macular degeneration, they're put on Avastin or Lucentis. And there's been a big fight between Avastin and Lucentis. They both do the same thing. They're called anti-VEGF. They stop your own body's vascular blood vessels, endothelial blood vessel membrane growth factor.
053.
Okay, so they affect the growth of new vessels. When you have macular disease, you have new vessel growth. Why would your body facilitate the growth of new vessels? It's kind of like when an old bridge is going to be replaced, but it's a critical through pathway or whatever, thoroughfare, they put a temporary bridge. Your brain is doing the exact same thing, building these temporary bridges. So when the vasculature starts breaking down, the nervous tissue being supported by that, the optic nerve, things of that nature, need help. So your brain creates these temporary bridges. Well, just like a temporary bridge is not in the perfect path where the original bridge is, it's sort of a little roundabout, or you have to little sidetrack. These new vessels are a little sidetracked as well, and it can impair vision because they're kind of blocking the light being focused in the back of the eye, the fovea. So someone smart, quote unquote, said, well, let's stop those new vessels from growing and vision will improve. And it improves, but it improves so marginally that Johns Hopkins came up with a new vision scale called letters to measure the most minutest increase in visual acuity. It's not 2080 going to 2040. It's like 2100 going to 2099. No one wants to report that. So they give you this letter grade. So in other words, the effect of visual improvement is marginal. But the problem is, when they do the injection, one red blood cell is going through your heart, the same one if we trace it, every minute. We inject the Lucentis or the Avastin, these anti-vascular endothelial growth factor drugs in the eye. It's around your entire circulation. So what if you're going to have a ischemic event? An ischemic event is a blockage. Vascular endothelial growth factor is there to create temporary bridges around that blockage. So the difference between someone who dies of a heart attack and just has chest tightening and a mild ischemic or maybe even a moderate ischemic event is the ability to bridge around that blockage. Vascular endothelial growth factor, by the way of a Lucentis injected in your eye, can turn the tide between you having an ischemic event and dying of a heart attack. Okay, and here's the statistics. This is right from their label. This is from the Lucentis label that nobody reads, is that I showed that fatalities in the first 2 years occurred at 4.4%, 11 out of 250 people. Anybody raise your hands if you want to change your vision marginally, but want to be have a 4.4% risk of dying in 2 years of a fatal heart event? Anybody? No takers. Yet so many people are on these drugs. It's a $4 billion a year drug. Okay, and then, but the real statistics is because the control people who already have vascular disease, so their rate of dying was 3 in 250. They already have vascular disease. And you know, my talks on the eye shows you that eye diseases are an indication of something going on underlying, and you have much higher increase in mortality. So here's the statistic. This is just a paper that shows that there's a very significant 290% increased risk of death compared with sham. That means no treatment, basically. And this is one of those mobs. The Lucentis is the thing that downregulates your vascular growth factor, is a monoclonal antibody drug, a biologic, if you will. I won't go into this in great detail. Let's get right to the statistics. Absolute versus relative statistics. Please read Doctoring Data, Malcolm Kendridge. Okay, great book if you want to see how the medical community games medical statistics to make it look like their drug is a whole lot better than it really is. So let's look at the Lucentis. 12 out of 250 died. The relative statistic, if they're reporting it honestly, now keep in mind, the label says 4.4%. That's absolute. They always tell you the risk in absolute and the benefit in relative. So if they were being honest, they would say your risk of dying has increased by if you take this, by 366%. Okay, that's the relative statistic. You know, but that's how they explain all the other things. So we do a little math, and it turns out that you get 8 extra deaths out of 250, or is a 3.2% increase. But you get very little. The reason why I'm saying this is It would be much better if I just said your risk of dying is 366%. But I mean, we need to compare apples to, that's why I have this next slide. We need to compare apples to apples. And we've been desensitized to think a number like 4.4 or 3.6% is significant because, oh, the benefit of these things are 30%, 80%, you know, really a nice number. But I mean, if a drug is really beneficial in a relative way, it's thousands of percent to become meaningful. Thousands of percent. Statin drugs advertise 28%. That's nothing. That's relative statistic. It's meaningless to you. Meaningless. So drug benefit reported in relative statistics, very large number. Drug harm reported in absolute statistics, very low number. We're not comparing apples to apples. So I prefer, as a scientist, to give you the low number of absolute statistics because that's really meaningful in your life. And I would say a 1% increase in mortality is a bad deal. Probably want to be at 0.001% before you take that drug, unless you're in a life-threatening situation. And then again, this drug does not improve vision. So the endpoint, or barely, so the endpoint for that increase in risk of 3.6%, and we can make it 4.4% if you work with me and Dr. Carter, because we're going to find out the reason you have macular disease in the first place and correct that. So now it's a 4.4% increase in mortality. It's a bad deal. So this is an important quote, which I'm going to end the drugs that do more good than harm. The New England Journal of Medicine is the top medical journal. Some would argue Lancet's number 2. And you've probably heard me say this before. If you publish your medical paper in Lancet, you're probably British, or the New England Journal of Medicine rejected you. Okay, that's how prestigious the New England Journal is. Arnold Palmer was the editor of the New England Journal of Medicine for about 15 years. And this is at the end of chapter 5 of my Alzheimer's book with Dr. Tremp. And I'll just read it to you. This is the editor of the New England Journal of Medicine that largely didn't have editorial control over his journal because of money. So the medical profession is being bought by the pharmaceutical industry, not only in terms of the practice of medicine, but also in terms of teaching and research, says Arnold Palmer, a Harvard professor and former editor of the New England Journal of Medicine, whose recent critique of the industry's influence in healthcare, published in the New Republic, won him and his co-authors one of the top awards for magazine journalism in the United States. The academic institutions of this country are allowing themselves to be paid agents of the pharmaceutical industry. I think it's disgraceful. And I have the reference in my book. So this isn't conspiracy theorists like Dr. Carter. This is one of the most prestigious guys and overseeing what is being published in the most prestigious medical journal. Unfortunately, he died. He broke his neck and died. He had a whole thing on breaking your neck and the horrible experience he had at Mass General as a chaired Harvard professor. But then this is what I wrote as a, complimentary to Dr. Relman's discussion. A pharmaceutical executive says, a physician's prescribing value is a function of the opportunity to prescribe plus his or her attitude towards prescribing, along with outside influences. By building these multiple dimensions into physician's profile, it is possible to understand the why behind the what and how of their behaviors. And then, of course, my tagline is, too bad healthcare doesn't use sophisticated methodologies like this to diagnose patients. And on that happy note, we shall take questions. Let me see. I got to find my, hold on for a second as I find my chat. So, Dominic, oh no, I have to go up earlier. Please mute yourself. Everyone, please mute. Okay. Thoughts on exposure to EMF reducing melatonin? Michael.
Yeah, I would say EMFs can do a whole lot of things. In reference to it directly reducing melatonin, I can't say that I know the mechanism of that, but again, everyone is different how they handle all of these interferences. This kind of goes back to a talk I did a few days ago on how full is your bucket. That it's filling up with all sorts of things, and everyone has the different capacities to detoxify. But I will say that melatonin can be extremely beneficial, not only for sleep, but also in combating the coronavirus, because most people don't realize that melatonin actually has very potent antiviral and antipathogenic properties. So that is one of the things in the protocol to add to the armamentarium, generally in the 3 to 4 milligram dosage of melatonin at night.
Michael, another one for you. What is the best way to support body health while taking pain meds, Tylenol, morphine, short-term while recovering from surgery?
What is the best way to
support body and health while taking pain meds?
Well, when you're taking Tylenol, Tylenol is metabolized in the liver, and it reduces glutathione production, glutathione being the body's main master antioxidant. So I would say try to get off of the Tylenol, but if you must take it, you definitely want to combine that with N-acetylcysteine and glutathione. You really want to do that very, very short term, if at all possible. Of course, the narcotics, again, you want to try to do that from a short term standpoint. But there are a whole host of other things, going back to the liposomal curcumin. I also prescribe peptides. So there are, various peptides that can help speed healing, remarkably so, as a matter of fact. So there are a number of things that can be quite beneficial after a post-surgical procedure to add.
Michael, do you want to just quickly mention the shockwave therapy again? We talked about that.
Oh, yeah. So, I'm the chief medical advisor for a company called Softwave TRT. The TRT stands for Tissue Regeneration Technologies. So we have about 200 locations nationwide, but it is an acoustic wave device that was developed out of the lithotripsy device, the device that breaks up kidney stones. But what they found was when they brought the power settings down, it had extraordinary, healing properties, anti-inflammatory properties, and all of these things. So that in and of itself can actually speed the healing process as well. So you could visit our website at trtllc.com, or I think it's now under softwavetrt.com. So yeah, amazing advice.
It also helps with pain.
Absolutely.
Yeah. There's a lady who just wrote something trying to endear herself to me, and she says that mainstream optometrists, in my humble opinion and experience, are all living in the dark ages.
Yes, they are. I know that from personal experience.
Yeah, at best, they're looking in the eye capsule and not beyond. But look up "Sick Eye in a Sick Body," published by a Swiss and Austrian researchers in 2006, and crickets. You talked about PPIs last week, but not this week. Please discuss how to transition off of them, and that's exactly it. You transition off of them, titrate down. Otherwise, you have this huge rebound. Yeah. If you really want, I'm happy to send you our guidance on how to get off heartburn medication. So if you want to reach out to us on our website, healthrevivalpartners.com, I can have that document sent to you. Is there a website that lists absolute stats for drugs? Jim. Are you kidding? You gotta get a magnifying glass and look at the label. But maybe clinicaltrial.gov might have some of this stuff. But see, the drug companies aren't required to submit all their data to the FDA. It might be in the clinical trial data somewhere. Yes, Lancet and NEJM retracted hydroxychloroquine, lost credibility in them. Clearly. Matter of fact, I wrote a paper that I thought that Dr. Carter and I wrote that I thought was pretty good. So I wrote to them. I told my entire team, we're going to submit this to the New England Journal of Medicine. We might as well get rejected by the best. And then I got talking on the phone to a deputy editor, and I said, look, after this hydroxychloroquine fiasco, you ought to, make up for your mistakes here and publish something that's really oriented on health, our paper. And they said, well, you can submit it if you like, but the answer was, it ain't going to get accepted. So I didn't bother.
But as a side note to that, it accomplished the goal of those articles being in those prestigious journals. Everyone heard about hydroxychloroquine being demonized. Very few people heard about it being retracted. Where, as a matter of fact, in Brazil, they were giving 5 to 6 times the amount of the hydroxychloroquine killing people. So, and, Dr. Zelensky is probably the main MD here in the US that is still trying to get the point across that hydroxychloroquine is extremely beneficial. And he and his team, are really making a push to let people know about that. But, again, the whole goal of this push for these vaccines was to pretty much demonize anything, of course, natural, and anything that was or is a generic drug where there are no profits to be had. Same thing, of course, with ivermectin. So,
Michael, you're a supplement for the high cortisol?
Oh, it's called phosphatidylserine or Serifos. So, however, that is a supplement, you would definitely want to have me do, or if you're working with another functional medicine doctor, you need a 4-point cortisol. You really need to have, your full 24-hour circadian rhythm of what your cortisol is doing and what your DHEA is doing, and preferably mate that also with other hormone tests. But a number of people, the curve for cortisol should kind of look like a slide. So for instance, when you're waking up in the morning, your cortisol levels should be the highest of the day. And then it should gradually decline all the way through until you go to bed at night. But, a lot of people have, a flat curve there, but a lot of people have at cortisol bumping back up at night, and they can't, they really can't go to sleep. So again, but you don't want to just take the, phosphatidylserine blindly like that. There are other things that have to, kind of put into that equation as well.
I want to answer a question about the eye, and that is cloudy vision. What I'm going to say may be controversial. I haven't really, but Dr. Tremp largely agreed with me and told me about it. So the process of the lens changing, you suddenly don't have a cataract that pops up. There's a process. So the process of early lens changes, you see what's called coma aberration. Coma aberration. And what happens, you have very sophisticated instrumentation that sees just the earliest swelling. Okay, this is a research instrument. And it doesn't necessarily mean you're heading down a bad path. You can get it. It's like everybody has a cancer cell. You have one, you can get rid of it. But it's just like, it's like oil on water. You put a little drop of oil on water, you see the spreading. That's coma aberration. The next, I believe, in the process is called pseudo exfoliation, or pseudo X, where you see these like Milky Way Milky Way little collections. Okay. Then the next phase is you see sort of a more aggregation. You might see the beginning of a cataract or very hazy one, or you may even see in the cortical cataract realm. Nuclear is what affects your eyesight. Cortical is the Alzheimer's cataract. You might see the formation of a little fibril in a little swirly little aggregation. Then you start seeing a more developed cataract. So if you're seeing triple vision at night or reflections or little stars when an oncoming car, it could be a sign of a pathological change towards this unfolded protein response. And it's something you should test out. But see, we use the eye as screening. It's a sick eye in a sick body, or a focal disease in the eye. And I see Dr. Loudon, he'll make sure I don't demonize the optometrist too much, but by the same token, largely agrees, because he was in practice for, I think, 75 years, Richard?
No, only 42.
Okay, 42 years. But these are things that all trace back to physiological changes. When you see pathology, physiological changes came first, and then risk factors came before that. So like, do the eye test, fine. If your eye is bad, if I see something in your eye, we're going to have you do the physiological tests and the risk tests anyway. We just know that you're probably a little more progressed compared to someone who has a clean eye. And the eye is a barometer for so many inflammatory processes, but not everyone. Okay, so it's not a perfect screening tool, but if we can catch 50% of things in people that are completely unaware that they're only apparently well, whereas in fact they're not well, that's a good thing.
Hey, Tom.
Yes, sir.
The point about the eye is it's a wonderful organ because you don't have to use invasive techniques in order to assess health.
Right. Absolutely. And Dr. Trump made a better point than you, Richard, of course. You have two eyes. And so let me go back to Lucentis. Okay, you only have one brain, but you have two eyes. And there's very good statistics on, let's say you have a macular disease diagnosis in one eye, but the fellow eye is clean. There's very good statistics on how quickly it'll migrate to the second eye. 22% in 1 year, 85% in 5 years. If your doctor doesn't know what the heck they're doing, you're going to be on that statistical pathway. If you have a good doctor that integrates eye to whole body health, like Dr. Carter, you will not have any migration. And I'm slowly publishing a paper from Dr. Trump that shows his data that nobody migrated into the good eye. And more importantly, they lived a longer, healthier life, difficult to prove statistically, but these are cardiovascular diseases. And I will do an eye talk, I have plenty published out there, but we'll do an eye talk, in a few months or something like that, and show you the profound statistics on eye pathologies and mortality. And unfortunately, I've got to run because I have a 1 o'clock. And I'm sorry for generalizing on eye doctors. Look, my son just graduated from optometry school. His patients love him. He was trained by Dr. Trump, and he does his best to give good patient care to everybody.
So, Tom, does that mean that we're not all in the dark ages? Positive development.
Not all. And the sad thing, like Dr. Carter and I have this colleague, Shailesh Kaushal, down in Orlando. And he's an MD, PhD, and when he's in the room with you, he's the smartest guy in the room. Okay. However, he's seeing 60 patients a day. Therefore, there's no way he can help those patients understand the connection between their eye health and their systemic health. And he has a pretty good grasp on it. Okay, but it's just not available to him within the context of the practice, the business of the practice. So anyway, thanks, Dr. Carter. Thanks, everybody else. Thanks, Richard.
All right.
Thanks for the questions. And we'll see you next week.
Thank you.
Next week, we'll be on the glycemic index.